Well, why don't we continue here on instability? So, Sahara, why don't you take this case?
Okay. 68-year-old male with shoulder pain, weakness, and limited range of motion for 2 months. And so there is a lot of edema in the greater tuberosity at the attachment of the supraspinatus. There is moderate tendinosis, and looks like maybe there's a Hill-Sachs deformity actually.
Okay.
Acute and chronic.
But this isn't the usual location for Hill-Sachs, is it?
Yeah, it should be more posterolateral, right? So it's acute fracture actually of the greater tuberosity.
Well, what do you think happened here? What's the mechanism of injury?
Fraction?
No, I don't think so here. Let's see, and then you can see that there's also what's going on up here.
It looks like the superior labrum is torn and avulsed.
Okay, but what is this?
That's a biceps labral complex.
Well, what's this?
Oh, is it? It's like bone actually. There's bony.
No, I think it's fat.
Okay.
So what's fat doing there? Okay, and then what's happening down here?
So there is fracture of the inferior glenoid as well.
Okay, so what do you think could be the mechanism of injury that would produce these bone injuries?
Impaction fracture?
Well, it's a little bit like a Hill-Sachs and a Bankart, except they're in a little bit different location. This is straight inferiorly, this is straight laterally, and then here we can see that fat in the joint space. That means that it's highly suspicious that you've got a fracture, and there's a marrow of fat that's extruding out into the joint space. Here are further images. This just shows that glob of fat floating around in the joint space here, and all the other kind of injuries. And here, now this looks more like a Hill-Sachs impaction injury. This really looks like a Bankart injury. So this was a little bit more, instead of a straight anterior dislocation, this was an anterior-inferior dislocation with these bone injuries, but these were more severe than we typically see, with actually a communication between the joint space and the marrow space, and this is intramarrow fat, which is extruded through the fracture into the joint space, which could be misinterpreted as a displaced labral tear. But on the T1, we see that it's really fat. Okay. So what do you think here?
So actually, let me just show that there's a Hill-Sachs deformity with edema.
Hill-Sachs with acute edema.
Yeah, and anterior labral fracture, or possibly a labral, like a Perthes lesion or something.
Okay, so this is a labral tear, and you got thickening of the periosteal attachment, so you can call that a Perthes lesion. And if you do an ABER view, it pulls off nicely, just like the textbooks say it should, and you can see the nice tear there coming right down through the anteriorly. So that's a typical Bankart lesion, and there you can see it on an ABER view. Here's another case of sports medicine injury. Again, this is a little bit more of a chronic Hill-Sachs impaction injury. Then we can see a lot of irregularity of the anterior inferior glenoid here, as well as a tear of the anterior labrum. So there's a Hill-Sachs, and here we can see the fracture of the anterior inferior glenoid. So that would be a bony Bankart lesion. And this is a combination of the torn labrum as well as bone here in the coronal images, if we go right through this area of the injury. And this is a bony Bankart, which always includes cartilage as part of the injury, as well as labrum as part of the injury. And then hopefully I have slides here. If not, I'll have to put some in, where we then typically need to measure the degree of bony involvement here nowadays to determine whether or not this patient can just get by with just a labral repair, or whether or not you have to do some sort of a bony augmentation. And we'll talk about that when we get to the surgical treatment of these, as well as how large the Hill-Sachs is to see whether it's going to engage or not through physiologic activity, and whether or not you have to do a special procedure like a remplissage, where you attach the capsule down posteriorly here to keep the Bankart lesion from engaging on the glenoid. But we'll talk about those when we get to the surgical findings and what kind of measurements you do to determine those factors for the surgeon. Okay, Sahar, what do you think of this case?
Okay, we have single view of the shoulder. This is a irregularity of the glenoid.
Yeah, so there's a little bit of irregularity here. It's a little hard to characterize it. And then we go to a low field MR scan. What do you think of this?
So in low field, I see a Hill-Sachs deformity, as well as like a Bankart in the anterior labrum.
Hill-Sachs, and then here's a nice bony Bankart where you can see separation, even on a low field scanner, bony Bankart. Here on a high field scanner is a bigger example of a bony Bankart fracture with a little bit of displacement here. Here are the articular cartilage. This one, it turns out if the Bankart involves more than 25% of the length of the articulating surface here, then typically they have to require some sort of a reconstruction in order to be stable. And in this case, if you do that measurement, this was slightly over that. So this patient actually needed a bigger procedure. And there's the Hill-Sachs lesion, which we can see back there. So this was an unstable bony Bankart. And if you do the measurements and do the ratio, this was more than 25%. Some people nowadays are actually decreasing it down to 20%, but most of the papers say 25%. And here you can see this is that large bony Bankart. And just by viewing it in the sagittal plane, you can see that it's large enough where it's highly likely that the golf tee is going to be unstable, because somebody took a divot out of the tee. So if you put the ball on it, it's just going to fall over. And here are the kind of measurements that people make. A lot of people make them in the axial plane, where you go through the widest part to determine, and you anticipate where the anterior cortex should be, and then you go down to the biggest cross-sectional length at the area of the Bankart lesion, and you do that ratio. In this particular case, that ratio is close to 50%. That's what's in the published literature. Some people prefer to try to do it here and get the ratio, whatever it is here. This is going to be an unstable lesion. And here's just another example of a larger unstable lesion that's going to require some sort of a stabilization procedure in order to be stable. Oh, there it is. Okay, so this brings up the concept of the glenoid track. And if you raise and lower your shoulder, what happens is that there's an area of the humeral head which is going to be articulating with the glenoid, and as you bring your humerus up, exactly where on the humerus the glenoid articulates is going to change. Obviously, that's what motion's about. So people have done studies primarily with CT, where they've put the arm through different range of motions to see where that track is. And it is something like this, depending upon the degrees of angulation you have at the shoulder. You can, if the arm is way up high, then the articulation between the glenoid and the humeral head is going to be up high, obviously. And as you bring your shoulder down to next to your body, that articulation is going to become more inferiorly, and this is the area that's called the glenoid track. And here basically is the articulating surfaces of the humerus with the glenoid, depending upon the positioning of the shoulder. And here's just another example where you can see where the contact surface is going to be. Now, if the Hill-Sachs lesion extends into the track, then that means that you're going to have an engaging lesion. And when you put the shoulder in that position, you're going to have a rough fragment of the Hill-Sachs lesion articulating against the articular cartilage of the glenoid, and sharp bone and cartilage don't like each other, so it's going to produce symptoms, often pain in that location. So when you do surgery for these, you try to do a surgery so that you limit the likelihood that you'll get an engagement between the Hill-Sachs lesion and the track. So there are several papers. This is one recent one in skeletal radiology, and the way that they like to do this is take the sagittal images. You put a circle where the inferior part of the glenoid should be, and this is what it should look like. When you have a defect here, you have the defect here. So they then do a measurement of the diameter of the circle, and then in the axial plane, the maximum depth of the injury to of the defect in the bone. And you take D times 0.83 minus little d. And this 0.83 comes from a research study done in cadavers where they looked at a bunch of cadaver shoulders and found that if you're trying to determine the width of the track, empirically, if you multiply d by 0.83 and subtract little d, or big D by 0.83, that tells you the width of the tract. And then to determine whether you're going to have the likelihood of engaging it, you subtract little d from it. The larger little d is, then the smaller the intact glenoid tract will be. Okay. Now then is what we have to determine: is the Hill-Sachs lesion large enough where it might contact the tract when people move their arms? And in order to determine that, then you take the maximum cross-sectional distance of the lesion itself, which we have in red here, and then there is a little segment here that goes between the periphery of the defect of the bone and the actual attachment of the infraspinatus tendon. Right there. And so you have to add the red part and the blue part together to get the width of the Hill-Sachs, or the Hill-Sachs interval is the sum of those two. Now, if the Hill-Sachs interval is less than the size of the glenoid tract, then the lesion is supposedly an on-track indicating a lesion, indicating that in extremes of the abduction and external rotation, the Hill-Sachs lesion will not cross the anterior aspect of the glenoid in the labrum, and it will not engage. And I always get confused by this, because to me it seems like if it's an on-track lesion, it means the lesion should go into the track. But they define it just the opposite of that. And it confuses me every time. So an on-track lesion is a good lesion. Let me come back.
This is a bit technical.
Yeah, a bit. So
for an orthopedic surgeon.
Yeah, right. Well, this is originally the orthopedic literature, and then this is just a radiology paper just describing the orthopedic literature to the radiologist, really.
Yeah, I know.
Go ahead, John.
I know. I was just kind of teasing a little bit.
Go ahead. Yeah. So
there's technical stuff in a way. I'm saying that with tongue in cheek, but it really is. Sometimes it goes a little too far, because when it gets to the surgery itself, but the bone sometimes will crumble, and when you're putting in a screw or using a drill, so you can't really predict mathematically what's going to happen.
right.
You just have to do it like a carpenter. You have a gauge, and then just do the best you can with it.
Right. So a number of our surgeons, when they send people in, they want us to do these measurements, and but not all of them, because a lot of people don't believe in it. But those who do, you basically then divide the patients into 4 groups. There's a group where the percentage of the injury to the glenoid is less than 25%. and you have an on-track lesion, which means that they're not engaging. And on these, they just do a straight Bankart repair. Group 2 is where the glenoid lesion is still less than 25%, but you have an off-track lesion, which means that there is engagement between the Hill-Sachs, and here they do a repair plus a remplissage, where again, a remplissage is just where you suture the capsule down to the medial aspect of the Hill-Sachs lesion, which keeps people from being able to move their shoulder into the engagement position. So it limits range of motion. And there's a group 3 where the glenoid lesion is greater than 25%, and you have an on-track lesion, which means it's not engaging. And here you have to do augmentation of the glenoid. So you either have to repair the fracture or put it back together again, or you have to put some sort of bone into the glenoid to support the glenoid. Or do one of the older surgical procedures that we'll talk about a little bit later in this talk. And then there's a group 4, which is again where you have a large Bankart lesion, but you have an off-track lesion, which means that they engage, and then you have to do the augmentation plus some procedure to the humeral head. Often remplissage may not be enough if you have this large of an injury, but this would be a much bigger surgery. John, do you want to comment?
Well, yeah, you have to make the final decision at the time of the operation.
Yeah.
And you can't. You can kind of assume that you're going to do something, but at the time of surgery, you decide.
Okay.
But the biggest problem we orthopods have is that the patients are not moving when you're doing the surgery. You're trying to complete something like a carpenter with parts that don't move. So it's a little tricky, and you get caught sometimes.
Okay. Sorry, it sounded like he said. Sorry, it sounded like you were saying that before the surgeon goes in, you're not necessarily that sure about what kind of procedure is going to be necessary. Does the MRI not give you enough information to anticipate that?
Yeah, it gives you information, but it doesn't tell you precisely what you're going to do when you get there. You don't really know what kind of motion you're going to get at the time of surgery because the patient is asleep. When you examine the patient cannot move the arm as much as you want to. And so you can measure tracks and so on, but that doesn't mean that's what you find at the time you open the you open the incision. If you're doing an open procedure, where some of these are, or you're doing arthroscopic surgery. So it's not quite as precise technically as we like to think of it. Using MRI, you can get very technical and measure very closely. But once you get your hands in the blood, things change.
Yep, great. Sahara, what do you think of this case?
And so do I'm sorry, and so do results.
Right.
So these are technically very challenging.
Sahara, what do you think of this case?
20-year-old basal feature with pain. There is tear of the anterior labrum with mild displacement. Yeah. There's partial tear of the subscapularis as well.
Subscapular. What do you think this is?
Is it the medial going humeral ligament?
I have some other images. Here's the sagittal image.
Okay.
So now here's the subscap. What's this? What is this?
This
This is a middle ligament.
yeah.
What's this?
Is it like super high attachment of the inferior glenohumeral
Here's the
ligament?
inferior glenohumeral ligament that's attaching way up here. Okay. And then here's the next cut. What are we seeing?
Okay. So there's some tearing of the inferior glenohumeral ligament, partial tear.
Well, wait. I'm sorry. Here's the inferior glenohumeral ligament right there. That looks actually black. This is it up here. This is the middle glenohumeral ligament. This structure.
Okay, partial tear of the middle glenohumeral.
We get a lot of edema in here. This is a tear of the middle glenohumeral ligament. And this is actually a superior insertion of the anterior band of the inferior glenohumeral ligament. And here's the edge of the labrum.
Well, they're all anterior glenohumeral ligaments. It's just in different positions. The capsule on the shoulder is very, very thin. It's almost like a synovial membrane. It's not very helpful, but the ligaments are what holds the shoulder pair for the most part. And that's why I think when you do MRI, you don't see the capsule very often, unless it's been injured and got swollen for some reason.
I think there are a few findings here. One is the edema in the posterior humeral head, like posterolateral humeral head. I wonder if there's some. This is pretty far superior, isn't it? Yeah. I wonder if that's a ligament or labrum. I would think probably a ligament anterior to the glenoid, just anterior to the glenoid. No, well that up there I think is transverse ligament, and yeah, that's probably a ligament of some sort. It's probably the middle glenohumeral ligament or something. I don't think it's labrum. Oh, okay. So here, so now we're seeing the biceps long head and again what appears to be a glenohumeral ligament injury. Yeah, I think it's well. Some of these images, it's not. I'm not sure if it's the subscap or the glenohumeral ligament, but there's something injured there. Here,
here's the subscap.
Yeah, that looks good there. That looks fine.
Here's the subscap.
Okay, maybe some volume averaging, but otherwise okay. Okay, so that's injured. So it's the middle glenohumeral ligament is injured, and and there's also a high insertion inferior glenohumeral ligament.
High insertion superior, and then there's a sprain in the middle. So yeah, similar findings. Okay.
I wouldn't advise this kid to pitch.
Okay. Sahar, what do you think of this case?
Okay, 50-year-old male shoulder injury with rugby tackle. I see some edema in the anterior humeral head.
Yeah, and we have to worry about the growth plate here, so that could be growth plate like this. Okay.
And it's mostly at the attachment of the subscapularis. The subscap itself looks okay. There's some edema, along the infraspinatus. As we go down, I'm concerned about partial tear of the infraspinatus, articular surface. Yeah, it's torn and it's retracted.
Yeah, so this is an avulsion of the posterior band of the inferior glenohumeral ligament, or reverse Hegel. So here, this is the infraspinatus or the teres minor, probably teres minor at this location. This is actually a little bit deeper, and this is actually the posterior band of the inferior glenohumeral ligament that's been avulsed off the bone here. So that's or some people call this a reverse Hegel because it's posterior rather than anterior. And it's about a little bit of bone coming off there. Okay, and here we have an axial image, and again, we're on instability. We're concerned about this area and through here. Here's part of the labrum, and there's another structure anteriorly with a little bit of increased signal intensity within it, right in that area. And then if we follow it down, we basically have two little black structures here, one that has a lot of increased signal intensity within it, and then we have the other one. The red one that comes down is the middle glenohumeral ligament because it's really attaching to the deep portion here of the subscap, and then the other one was the labrum, which was abnormal. And then we also see some ossification going into the labrum. So this is a degenerative tear of the labrum, as well as a strain of the middle glenohumeral ligament. And then we have the ossification of the anterior one. Okay. And here's just an acute Hill-Sachs. We can see the Hill-Sachs lesion, and we can see the tear of the labrum with attachment here to the periosteum. So another Perthes type lesion. Okay.
And that last one was a subluxar, was not a dislocator. No Hill-Sachs.
Wait. This one right here? This one?
Yeah. I'm trying to figure it out.
Yeah.
There's no Hill-Sachs.
Yeah, there's a Hill-Sachs. This is a big impaction injury right here.
Oh, okay, got it.
Yeah, and then there's also a little bit of edema of the glenoid here as well.
I missed.
Okay.
So somehow I.
All right.
Thanks.
Yeah, sure. Tahar, what do you think of this case?
Okay, tear, Perthes evolution. I see some tearing of the anterior labrum. There's some increased signal intensity along the anterior labrum.
Periosteal attachment. Now this was on 4504. So there we can see a labral tear. And then the patient came back a month later, and this is what this patient looked like just 1 month later. So what's happened?
Okay, the labrum is more displaced anteriorly, and there's some scarring of the capsular attachment.
Yeah, look how thickened it's become. That's what it was at the time of the acute injury, and just a month later, see how thickened it is. We've seen examples where ligaments thicken after injuries, or at least we call them that. And here's just an example of what it looks like. Due to the injury, this is healing, the body trying to attempt to heal the injury to the capsular insertion, and it's much more thickened.
Is that a peel back, John, that's healing?
Yeah, you have an injury to the periosteal attachment all the way back to here. That's right, and it's healing with scarring. Posteriorly, which we'll get to a little bit later, these will often calcify, in which case, what's it called? No, it's not an ALPSA when it calcifies.
Bennett lesion? Or?
Yeah, it's a Bennett lesion posteriorly, and the mechanism is these are chronic tears, and the healing this chronic injury will calcify, and you'll get a little calcification. But we'll talk about that when we get to Bennett. Okay. And here's a Perthes. Here it is on a regular MR study. You can clearly see the tear, the periosteal attachment. When you go to the ABER view, you can see in this case it pulled off a little bit, but still has a periosteal attachment. Okay, Sam?
The regular was far better than the ABER.
Yeah, sometimes.
No, I mean, you just showed it.
In that one, right. Here's a different one, though, which I'm going to show the same things in this one. This 17-year-old history with multiple dislocations. What do you think of this one, Sam?
I don't see a posterior labrum, so I'm wondering if the dislocations were posterior.
Yeah, this was an anterior dislocation, but I agree, the posterior labrum is blunted here. This is posterior inferiorly, I would really be concerned about a chronic injury to the posterior labrum. And we'll talk about those later as well. But then they did an ABER view, and this is anterior on the ABER view. That's posterior. So what do you see? So
there's a tear, yeah.
And that are the same areas.
So there's a tear, just you can't see it on the.
So this is one of those rare cases, in my experience, where the ABER view actually shows the anterior labral tear better. And I've had some where it's seen better in the regular view. So it's yeah. Okay. All right. Sahar, what do you think of this case?
Well, so there is like low intensity signal in the anterior capsule, but I don't see the labrum very well. I'm not sure what's the name of this.
So this is a T1 arthrogram, and here's the fat set that goes along with it.
Okay, so there is avulsion of the capsule, and there is contrast getting into it. So it's gonna be let's see, Bankart spectrum.
So this is just a labral tear and a large paralabral cyst. And this just points out that quite commonly the paralabral cysts will not fill with contrast. They're generally filled with a gelatinous type structure. It's generally not fluid, even though it looks like fluid, but it's gelatinous, and I don't think the contrast can diffuse into it very readily. If you bring these patients back and scan them a day later, you'll find that you'll get some enhancement of the gelatinous material because it just eventually will diffuse into the paralabral cyst. But commonly, if you do arthrograms, you will not fill the paralabral cyst. Just be aware of that. Okay. Okay. What do you think of this one, Sam?
A question of a labral tear. Posterior labrum is a little bit blunted. The anterior labrum is really small, and I mean, okay. Is that what's that behind? Just anterior to and just posterior to the labral. I mean, to the glenoid surface. Yeah, what's that? I guess it's a piece of the labrum that's been torn off and displaced.
So and here's a Hill-Sachs. So this patient had an anterior dislocation, and that's a displaced. Excuse me, displaced labrum anteriorly. Now, often the labral tear will displace, and it'll still be connected. It'll basically it's a band that gets torn off that medially displaces, and then it can often scar down here. So at arthroscopy, you may not be able to detect it. You'll just find a small anterior labrum. So MR can be very helpful at finding these displaced labral tears, because what typically will happen with these is that the surgeon will go in, if they want to repair it, they need to free this up. So they need to find it, get it free from the scar tissue, put it back in place, and suture it into place. And we've had several athletes where that's happened. This is a similar finding here. We can see the displaced labrum in this location right there. And this is often called an ALPSA lesion, anterior periosteal sleeve avulsion lesions. Again, it's fine to use this term, but I would also describe it. So, it's a fairly recognized term, but again, with any of these kind of terms, I really prefer to give a description of what the findings are so it's clear what they are, and then you can give a name for it if you want. And here's just another example where it's displaced, still a little bit of a thickened attachment to the periosteum, and we can see a little tear of the articular cartilage there as well. Here's an example. This was a young adult baseball player, and here we can see that there's a tear of the labrum and a displaced, so another ALPSA type lesion like the others. And here we can see the capsular attachment in that location. This was on 4/21/07, and here we can see the acute impaction injury. The patient did not have surgery at that time. but presented almost a year later, and this is what the findings were. And we can see now all that irregularity that we saw before, all this fraying here due to the acute lesion has pretty much healed, and what we end up with is very smooth margins, and it's fairly easy to miss the fact that this is the displaced labrum. And the surgeon in this case went in, freed this labrum, put it back up again, and repaired it, even though it was a year later. And the patient ended up going back to pretty high-level sports. He was a Major League Baseball player.
You have to tighten that capsule up too.
Yeah.
You have to imbricate the ligamentous structure.
Okay. Sahar, what do you think of this case?
Okay, so we have two axial views of the shoulder, and there's a tear of the anterior labrum, and it seems that it's extending to the articular cartilage, and maybe it's a little bit displaced.
So this is what's called a GLAD lesion, or glenoid labral articular disruption. Personally, I'm not enthusiastic about the term, as you can tell, but they're in the literature, and people like to pass them around as buzzwords. But in this case, I really like to describe the tear here of the labrum, that you're undermining the labrum, give the measurements of it, and then the fact that the articular cartilage and the labrum is abnormal as well, which we can see better on other images. And here's another example of the same thing, where we have a tear of the anterior inferior labrum, which is displaced a little bit here, but we can also see that it involves the articular cartilage, where this is an oblique tear in the articular cartilage here to the surface. And then I like to give the size of these. And you can say it's a GLAD lesion, but I think it's much more important to describe the findings so it's clear to people what they're going to be looking for when they get in there surgically, rather than just saying it's a GLAD lesion and not really describing the findings and measuring the findings.
You have to be a masochist to feel glad about it.
Good, John. I like that. Okay.
It's Friday.
Right. So here's the case. Here's a T1 weighted image. We can see a lot of increased signal intensity within the anterior labrum. Stir image. And then here we can also see increased signal down and through here. This is on 3/5/2005. This time it just looks kind of a diffuse edema. And this is now the same patient. This was 3/5/05. This is 5/16/05. So about 2 months later, and we can see now, not in the time of the acute setting, but we can see these really sharply defined tears of the anterior labrum. We can see an abnormality within the cartilage, and we can see this large bone injury here, which we could not see on the original study. This patient has not been re-injured. This is just the progression of the healing response to the original injury. Just to give you an idea of the time course where some of these changes can occur.
That was how long?
2 months. Okay. Is it Sam? Is it your turn?
I think so. This is another GLAD lesion. I mean, it has a cartilage defect there, yeah.
And here we can see it on the coronal images as well. And see it's an oblique tear going up higher. Okay. Sahar, what do you think of this case?
An OB feature with pain and weakness. So there is tear of the anterior labrum. It's actually looks like it's extending to the bone, to the bony glenoid.
So you're saying this is bone, so you think this is a glenoid fracture here, right?
Yeah.
This is the labrum coming up here. And if we here's on the sagittal images, we can see that area of increased signal intensity going up and down there. And this patient went to surgery, and this wasn't a fracture. What this was a large labral ossicle. So the entire anterior labrum was just ossified, and this was all ossicle within the labrum.
Old injury.
Yeah.
I mean, it could have been an old fracture by the imaging, right?
Well, actually, it looks like there's no blunting of the anterior glenoid here. And when they went in surgically, they felt that this was all just within the labrum, that the underlying bone was okay. Okay. Yeah, do this.
41-year-old pain and aching for 5 months. Well, the anterior labrum is ill-defined, a little bit increased in signal, and there's not a whole lot else, I don't think, here. There's some edema in the humeral head posterolaterally, against some just blunting. Oh, okay, so cyst.
Come back here with some signal here anteriorly. And then a little bit further up, we can see some little cystic changes there.
Yeah. I don't. You're just.
So this was called an anterior labral tear in this particular patient. So here it's thought there's an anterior labral tear right here. Maybe a little bit of Hill-Sachs, even though this is a little bit too low for a Hill-Sachs. That was on 8/23/13. And then this is.
He's had this for a long time. At the age of 41, you usually do real well at the age of 41 if you have an acute injury. So he's had this predisposition for subluxation for a long time.
Okay.
He probably never did dislocate.
Okay, now the patient came back, and this is about 3 months, 3 months later, and this is what it looks like. This is now an arthrogram inferiorly. If we come up a little bit higher, come up higher, come up higher, come up higher, and then we come back up to that little cystic lesion here. So what do you think's happening here?
I think that there was.
Fell off a horse.
Here are the sagitals.
Oh, there's a high, superior attachment of the inferior glenohumeral ligament.
So this is a superior insertion of the intraglenohumeral ligament. I just want to point this out. So it doesn't look too bad here, and here. So this is what people call the tear. And if you just follow around here, if we had all the cuts, which we don't have here, but what you can see is, let me see, this is really where that lesion is going to come from. Here it is. And then if we go a couple of cuts higher, this attaches right up to the typical location. And if you go to the sagittal images, without arthrography, you really can't make out the anatomy here. But then if we put contrast in here, this is a very typical, with contrast, it spreads everything out. Here's the labrum. Here's the position of the anterior band of the inferior glenohumeral ligament. This would be where the middle glenohumeral ligament would attach. Come up here, this would be the middle glenohumeral ligament, anterior band, and labrum. And this is a typical notch that you can see when you have a superior insertion. Coming up higher, here are those three structures all coming together, to which they finally come together in one location. So this is a classic example of a superior insertion of the anterior band. And and on the sagittal images here, where we have contrast, we can separate the middle glenohumeral ligament from the superior insertion of the anterior band. So just pointing out this anatomy and over again, because it's a common mistake that I've seen in people who aren't aware of this possibility. Okay, here's a 43-year-old male evaluated for a subscap tear. The subscap looks pretty good here. We have to wonder a little bit about what kind of anatomy is here. If we go up, we're seeing some increased signal intensity. A lot of increased signal intensity here as actually we're going down. And here's the labrum. This is that structure that we see anterior to the labrum here, but it has abnormal increased signal intensity within it. If we go to the sagittal images, now we can see the subscap. This is actually the anterior band of the inferior glenohumeral ligament, which is thickened with increased signal intensity within it. And this is a tear of an anterior band of the inferior glenohumeral ligament that had a superior insertion. So,
how common are these?
Uh, it's not all that common that they masquerade as a tear, but we see them fairly frequently. If you look for them, you'll see them. Yeah. I don't always point them out because they aren't issues most of the time, but sometimes they can.
And this isn't acute, is it, John? It looks like an old stuff.
Well, they're
43.
yeah,
43.
the symptoms were acute. I think this was an acute injury, and this looks acute, John, because there's a lot of edema in it.
Okay.
Right in here.
I thought it was an aggravation of a prior, because isn't that a Hill-Sachs lesion there?
I think that's just a chronic insertion. This is marrow. This is normal marrow, just like over here. So I don't think there's an acute bone injury, and I think this is just a chronic tract.
Okay.
It was misinterpreted as a Hill-Sachs.
Gotcha.
Okay. Why don't we stop here, and then we'll talk about the things to look for after surgery when I come back from the International Skeletal Society meeting. Okay? Thanks. Any questions?